Good morning, and thank you, Kaveh, for the and Dr. Levesque for the kind invitation to participate in this workshop. This morning I'm going to talk about a very specific problem related to wireless video capsule endoscopy. This is an academic peculiarity, particularly in Massachusetts, so we have to disclose almost anything we do these days. But I work with Given Imaging, Intramedic, and the Olympus Corporation. I'll take the liberty of just going through the anatomy of what I'm dealing with on a day-to-day basis. The esophagus, stomach, and duodenum are pretty easily accessible by conventional endoscopic technology. That's been around for nearly 40 years now. You can get a little bit further with what's called push endoscopy. That gets you down maybe 3 or 4 feet into the small intestine. And I should remind you that the small intestine is a tube that's about 20 foot long. It's wrapped up on itself, and it's completely featureless. So we don't know where we are when we're within it. And then there's a relatively recent technology called deep enteroscopy, where you take the small bowel and sleeve it back onto a scope. And that allows you to get fairly well into the small bowel, possibly even half or more of the way through that 20 feet. And then retrograde colonoscopy, again, has been around for about 30 or 40 years. We can get into the lower few inches of the ileum, which is coming back upstream. And deep enteroscopy can also help us get much further up. And very occasionally we can actually meet in the middle. If you put a tattoo where you get to when you do the deep enteroscopy from the mouth, leave a tattoo there, come up from the lower end, you can just occasionally see that tattoo, but it's the rarity rather than the rule. So with that anatomical background, what is capsule endoscopy? And this is a device that allows direct, non-invasive visual examination of most of the mucosa of the GI tract. Those images with the FDA-approved devices are transmitted by radio frequency and then are downloaded for clinical review. And I think it's fair to say that capsule endoscopy has now become the gold standard in evaluating suspected or actual disease of the small bowel. The evolution of the technology, it started with Paul Swain and an Israeli group back in the late 90s when they took really off-the-shelf spyware and put it together in a small package, swallowed it, and found they could actually image the mucosa of the small bowel. And then over the ensuing decade, we've got 2 commercial products and then 3 or 4 in the wings with various differences between them. And if you look at the just bear in mind, this was the original sensor array, a huge recording device and a large battery pack. And then this has evolved with time to a slightly similar but rather lighter sensor array. This one's the Given device, this is the Olympus device. And we're slowly evolving. And I'll say more about the sensors in a moment. The software started with this rather fuzzy image. I'd had an interest in what we call obscure GI bleeding for about 15 years prior to the advent of this technology. I stumbled on it at a focus group and saw that this potentially had enormous opportunity for examining the small bowel in a way we never were able to before. And then as you see, as you go along this panel, the imaging techniques and quality has improved with time. And there are various adjuncts that have been added in with software modifications which allow for quicker reading and greater image quality and reading techniques. So that now when we started in 2001 with the first FDA-approved device, you could just view 1 image at a time. You can see 2, you can do 4, or even a mosaic image. The whole video system takes about 55,000 images over an 8-hour period, 2 frames a second in most devices. So that's actually a lot of reading, but some of it, fortunately, you can get around, and a number of algorithms have been developed to facilitate reading. I don't want to spend my life reading these videos. And here's what some of these capsules look like. That was the original tethered device. Then it became independent with the battery development. And then this is the latest Olympus device with six LEDs that provide a light source. The lens is sitting in the center here. The electronics behind that, batteries, and then the transmitting device at the far end. And this is what the transmission arrangements have now been reduced to, simply because we've now got 3 sensors here instead of 8. The recording device and battery pack in this simple shoulder pack here, which the patient can easily go to work with. It's an 8-hour study in general, and patients can simply pick up the device early in the morning, swallow the camera, come back late in the afternoon, and have everything downloaded. So these are the 2 systems. This is the SB2. Both of the small bowel devices only image in one direction, and there are other devices, one for looking excuse me, at the esophagus and one for looking at the colon, which have double-ended imaging capabilities and generate a lot more data. By way of physical comparisons, these devices are quite large pills, but 99% of the people can swallow them without much trouble. They weigh very, very little. There's probably in the order of 2 million of these devices being deployed over the last decade. And in fact, there's now an environmental concern that these, which are pooped out, are now starting to clog up in the various sewage disposal systems. I think that's kind of overdoing it, but nevertheless. Resolution is quite variable, as you can see here. Frame rate of the 2 FDA-approved devices is 2 frames per second. This one, which is just about to undergo FDA evaluation, has 3 frames per second. These 2 have radio frequency transmission, and this, the Korean device, uses what they call human body communication. They use the body itself to transmit the signal and then pick it up with a sensor array. Field of view is around the 150-degree mark. What we thought originally was that these capsules move through the small intestine in an axial fashion. Turns out that's not entirely true. They do tend to tumble. So with 150 degrees field of view, you're not going to see all the mucosa. You see a lot of it, but it's not complete. And then if you have time on your hands, there are real-time viewers available for each one of these, which allow you to see what's happening at any particular point in time. Clinical applications. The primary one is what we call obscure bleeding. That is when you've done your upper endoscopy, you've done your colonoscopy, and the bleeding is presumed to be somewhere in the middle. Occasionally, those 2 standard techniques are deficient, and you pick up bleeding either in the colon or in the stomach. But that's by far the major role for this. Crohn's disease, an unpleasant inflammatory condition of the small and large bowel. This is a great device for making an early diagnosis of that condition. We can detect small bowel tumors. These are relatively rare compared with colon cancer, but nevertheless, they're somewhere between 8,000 and 12,000 a year. And one particular type is becoming much more common, has been a 4-fold increase in the last 20 years. And we're able to survey these patients with what we call polyposis syndromes. They genetically are predetermined to develop polyps in the small intestine. Now we can non-invasively follow these people quite efficiently. And then there are various other diseases, celiac disease, the allergy to wheat, which we can follow if it's a difficult problem, either diagnostically or in terms of recurrence. Other clinical applications, chronic diarrhea, assessment of disease activity of Crohn's disease. Can we find strictures? Often notoriously difficult to find in the small bowel. Abdominal pain is not a good one for this technology, simply because the yield is low, but abdominal pain is astonishingly frequent. So what is my problem? The problem is, where are we? Where is the lesion? Where is the capsule in that 20 feet of small intestine? And I'll show you in a moment the primitive system that's been used to date, which has been basically a 2-dimensional algorithm, which is a trigonometric process, but it's conspicuously unuseful to the extent that Gibbons actually discontinued its use. And again, what I would like to do is to try to reference whether, if you like, the bony parts are, this is the rib margin here and here, and the pelvic bones are down here and down here, is with some sort of reference of where we are within this this knot of the small bowel, which is a three-dimensional issue because it's stacked up on top of itself. I will just give you, if I can, that's interesting. Any of my technical friends like help me out with this? No. Can you see if you can get it to work? It's a case of one picture's worth 1,000 words. Microsoft, in all its wizardry, has made running videos on laptops a nightmare. Perhaps that's something the group could consider, how to solve this problem. It was running a few minutes ago.
Is the video there? No, the video is not there. The video is not in that folder.
Copy the video together. I need the video. I need to copy.
This video is not in the folder. Do you have the?
Well, don't worry about it. It's sorry. I'm not going to spend a lot of time trying to track it down. But anyway, this is what the desktop looks like for reading these videos. This is your primary image. This is actually a rare one. The capsule moves very rapidly out of the stomach into the duodenum and around what we call the duodenal sweep. And this is 5% chance of seeing this. This is where the bile duct drains into the small intestine. We only see that about 5% of the time. You have a set of VCR controls here. Down here, images, if you want to select particular images where there is an issue of an anatomical abnormality or where you see active bleeding. This is what's called the color bar, and this is 8 hours of imaging, and it gives you color, and here is what's called a suspected blood indicator, which gives you some idea of whether there's blood. However, about 60% of the time or more, these red marks just simply indicate bubbles and have no diagnostic value. And then here is this algorithm, or the representation of this 2D representation of where the capsule is in the anatomy. But most of the time, gives you actually very misleading information, and it simply is not useful clinically. So what do we use to access the position of, or assess the position of the capsule? The primary one is time. This only happens about 80% of the time, simply because what we take is the first point of leaving the stomach, the pylorus. We then go through 20 feet of small bowel, get to the ileocecal valve, and then assume that the motion between those 2 points is linear, and then make a best guess as to where that lesion actually is. However, the linearity is far from true. There's all sorts of anatomical and physiological factors that alter motility and the progress of that capsule through the small bowel. And maybe the disease process, maybe adhesions, which are external scar tissue, if you like, between loops of bowel. All sorts of things can either speed up or slow down progress of the capsule through the small intestine. The other problem is with that 20% that's missing is that the transit may be incomplete, either because the battery runs out before it gets to the ileocecal valve, or there is an obstruction or whatever, so that if you can't see the IC valve, you even lose that linearity, so you're completely stuck as to where the capsule might be. So it really becomes a guessing game. There is one paper to date which has started to look using image analysis as to how the motor function of the intestine works with respect to collecting data from these images. It's a paper from Spain, published 3 years ago, represented 5 years of work, using computer analysis of these images. And it does separate out people with abnormal motility from those that have normal motility, but it doesn't give you any spatial information. So I leave this with you to provide some assistance, thoughts, ideas as to how we can crack this technically significant issue. Because from the patient's point of view, it's very important that we know whether or not we can get it with one of our endoscopic techniques, gives guidance to the surgeon where he needs to go, or do we have to resort to a rather cumbersome technique which has been around for 30 years or more, of what we call intraoperative enteroscopy, where you actually open the patient up, you take the bowel out, and then put a scope through it physically and examine the bowel in a rather traumatic and tedious fashion. So is there a methodology or methodologies that we could use to improve location of the capsule, both longitudinally and also with a 3D point of view, to see if we can reference that 3D image or identification of that area to the fixed points that I mentioned in the intestine. Thank you very much.